For our next topic, we have vaccines covered by one of my partners over at Tanner Clinic, Dr. Candice Smith. And Dr. Smith's talk is sponsored by our partner, Tanner Clinic. So if you're associated with Tanner Clinic, you can raise your hand or stand up. And so thank you for your sponsorship for Dr. Smith. I'd like to welcome Candice up to the stage.
Okay, thank you so much for the opportunity to come here. I like talking about vaccines almost more than anything, so super glad to be here. I have 5 main vaccine topics in 30 minutes, so I'm going to try hard to stay quick moving through all of those. Some of the vaccine topics are that they're new vaccines and we need to figure out, familiarize ourselves with them and the recommendations. Sometimes it's an old vaccine that has new recommendations, and sometimes, we just need to be updated on what are new risk factors that are applying so that we should get vaccines out to more people. I have nothing to disclose. This is starting with RSV vaccines. We can note fusion protein F here on the RSV virus. That is going to come up later. So when we talk about the yearly burden of RSV vaccine, I think everybody focuses that young children get it. It's hard on young children. They need a lot of support to get through their RSV infection. I think people forget that it's significantly impacting older adults. And so when you look at the numbers, you should think that they're very familiar and that they're very similar to how influenza affects older adults. And especially when you look at the hospitalization rates and the death rates in our older adult population, that should be something that when you talk to people about their risk of RSV, the numbers just kind of have these numbers in your head. And especially when you talk about if people are going to have significant problems from RSV. This slide is from last winter, just this winter we just barely got through. And when you look at COVID, vaccinated, unvaccinated, flu, vaccinated, unvaccinated, and then you look at RSV, RSV has actually a higher burden of who needs more invasive ventilation once they're hospitalized. So I think it is, maybe you're going to get sicker with RSV than you would with flu and COVID. That's something to mention. Okay, so when we talk about the new RSV vaccines, we're talking about 2 main categories. And the categories are we protecting an infant, getting an infant protected against vaccine? And that is through 2 main modalities. The first modality is an infant monoclonal antibody. That's nirsevimab. And that is an option to be able to get to the baby. I liked being able to, people are always saying this is a brand new vaccine and it's so hard on a baby. I like to remind parents that it's not a vaccine, and because it's passive immunity, it's not hard on a baby. Then we have another option, and that's a pregnant woman gets the vaccine. And again, this is active immunization of a mother, which then is passive immunity to the baby. Parents often wonder, what's the best option? What should we do? I just like telling them the numbers. Sometimes they just a maternal vaccine seems much easier for a family to work through than an infant shot of a monoclonal antibody. So that's one thing people kind of like to weigh. And then as far as efficacy, the N numbers of preventing hospitalization, the vaccine to the pregnant woman, that's about a 60% reduction of hospitalization rates. And then we're about an 80+% rate if it's the infant monoclonal antibody shot. So that's focusing on infant protection. Then if we focus on older adult protections, there's the 2 main vaccine options, and they are different. I'll get into the differences in a little bit. So why do we have all these new vaccine products in 1 year? I don't know if anybody else kind of felt whoa, all of a sudden everything's here, and why all in 1 year did everything change for RSV? And that all goes back to some NIH studies. So the NIH cracked the code this decade, right? So this decade we had the NIH crack the code of finally what it was that got us a target, something to move forward for with vaccines. And what you can see is that we have that spike protein, the F protein of RSV, and everybody figured out how to stabilize the pre-fusion form. So once we had the NIH saying, look, we have the stabilized pre-fusion form, then they figured out, was it an antigenic, little protein sitting there, and did the immune response to this protein, did it last, and did it prevent further infection? And once all that was cracked, then it was so exciting because we had a pathway moving forward to protect against RSV infection. So that's why everything came at once, because a huge breakthrough by the NIH, and then we have everybody knowing that the pre-fusion F protein got all the antibody response and protection. So the two vaccines, how are they different? How are you supposed to recommend one versus another to a patient? Everybody is really into the details of vaccines. I think especially ever since the COVID vaccine, they want to know what brand does what brand does another, what are the side effects of each. So we have the two main options. Again, both of them are the pre-fusion spike F protein. So that's their basis. The Pfizer one is bivalent, so it targets both RSV A and B, and then that's its main difference. Then the GSK one's main difference is it's adjuvanted, and so the adjuvant's familiar to most vaccinologists because it's the same one that was used in Shingrix. So Shingrix is the zoster vaccine that we've been using for years now, and so that same adjuvant is there, and the adjuvant is there to enhance the immune response. So that's nice for people to know. That's the main difference. What are the ACIP recommendations then? So what are you supposed to do? What are you supposed to be recommending? So we're supposed to be recommending all infants under 8 months age get nirsevimab. And going into their first RSV season. So the caveat there is the mother did not receive the vaccine during pregnancy. So if we're not going to do it if she did. If the mother's vaccine status is unknown, you're going to have a discussion and trying to figure out what's what. You will give the vaccine if the mom had the vaccine within just the last 14 days prior to delivery, then you'll still give nirsevimab to the baby. One more thing to remind you guys on nirsevimab. You have babies going into their second RSV vaccine who do qualify for another shot of nirsevimab, and your off-season babies are in a holding pattern. So your baby's born April to October, just sit in a holding pattern, and then once RSV season starts, then they all will need their nirsevimab shots. So, and it's been studied, it's been fine to add that into the 2-month, 4-month, or 6-month visit, depending on where that baby is in its holding pattern. So it'll be a busy catch-up time, I think, and it's nice to let just parents know once that baby's born and hanging out, around now, that that'll be the plan once RSV season gets closer. Then, for pregnant women, the recommendation is between 32 and 36 weeks that they get the vaccine, and then move forward that way. And then the older adult vaccine, those options are that the recommendation right now, and I'll update you, but basically if you're over 60, you're going to use shared clinical decision-making to decide if that single dose of RSV vaccines should be given. Shared clinical decision-making is difficult to implement, so everybody knows this, that it's supposed to be this good discussion where we talk about, well, what are your patient risk factors, and now what are my recommendations, or what are my feelings as a healthcare provider about the vaccine, and it's supposed to be this nice discussion where everybody comes to what is kumbaya in the middle. The hard part about it is it's super difficult to implement, and everybody knows that. Everybody knows that they don't really know. It's hard on the patients, and it's hard on the healthcare providers. So what are the patient risk factors? That's nice to go over with patients. So for RSV, you're going to go through comorbid conditions. You're going to go through any frailty, being over 75, especially long-term care facilities. Those are your big ones. The comorbid medical conditions I listed, it's a really long list. How do you know what to prioritize? That comes from this next slide. Again, this is a good study saying if you're going to be hospitalized with RSV, what's the comorbid condition that's most common and has the most severity. So just remember from this slide, chronic kidney disease, COPD, severe obesity, and asthma. So just that's your quick list that you're going to focus on when you talk to patients. Everything on this list has some severity associated with it, but I would say that's your focus. And then remember that over 75. So I think this slide is important when you look at hospitalizations, because the 75-year-olds definitely take the biggest hit. But I mean, there's 18 to 50-year-olds who are hospitalized, you can see on the list with their RSV infections. And then you see a big chunk over 50. So then why is the vaccine recommended for over 60? So stay tuned for a moment, I'll get you there. Coming from the vaccine clinical trials, these were big vaccine clinical trials. So the 25,000 in one, I think 37,000 in another. And so we've got big numbers, and these numbers at this point are 3 years out. So it's nice now that we have some vaccine clinical efficacy looking at multiple years. Based on what we have vaccine efficacy that does last through the second year for both of them. And good vaccine. The first season is great vaccine efficacy, I think, for both of them. And then the second year, it drops off for both too. When you look at the difference in the drop-off, I also like to point out that the time frame is different for each clinical trial. One clinical trial checked early on in the second year, and one did later. And so it's kind of comparing apples to oranges when you look at the second year. So that's where we're at. We definitely know it lasts possibly that second year pretty well. Then the small print of the vaccine clinical trials is that the vaccine clinical trials did not focus on anybody really over 80, so we don't have good data there, and didn't focus at all on the patients in long-term care facilities. So we don't really know the immunogenicity and vaccine efficacy in that population. And this really was because the vaccine clinical trials happened during COVID, so it was kind of impossible to get that population pulled into a clinical trial. There is data gathering right now on post-licensure observational data to look at the protection among the greater than 75 in nursing homes. That's being gathered, but it's just not available quite yet. Okay, so this first year, the vaccine uptake for RSV vaccines was in the 20%, so that's great for a brand new vaccine that came out, right before the season started, but it's not awesome. And so the details of why it's not awesome are in this slide. And basically we have people feeling it's too new, people not trusting government, people not trusting pharma, and we have people not getting a healthcare recommendation. The healthcare provider, didn't know either. So again, this is something that we hope more time, more education, and discussing about the shared clinical decision making. The safety considerations, just came out the February ACIP. This is the Guillain-Barré safety signal that was seen. It was calculated, really small number of events total. The data's, again, this is the data. The background rate would have been around 5 cases per million. There's more cases with both vaccines. And you can see the vaccines are listed as just RSV vaccine of the pre-F, that's the spike protein, and then the pre-F plus the adjuvant. So those are how the two vaccines are listed. And then you can see that the GBS rate is greater for one vaccine versus another. Yeah, the safety signal was seen. With the adjuvanted vaccine, that safety signal is not statistically significant. It is statistically significant for our non-adjuvanted vaccine. So it'll be a discussion point where Guillain-Barré is a risk factor at this point. Studies are small. We're waiting for more details. So that's our big safety signal so far. And again, I think it's a small risk when you look at overall risk factors. What to expect in this coming year for RSV vaccines. As you can tell, I've kind of led into that a lot of things are being discussed, and what do we think might change? So the first thing is Moderna has an RSV vaccine coming out. So it'll be an mRNA vaccine. People will have all their feelings about mRNA vaccines at this point. But it's got good efficacy. The phase 1 clinical trials are done. They've been presented to the FDA and ACIP, and they're good. And the safety signals are also good. So they've looked at whether or not they have GBS signals, and they don't at this point. So the June ACIP is scheduled to meet about RSV vaccines and kind of make a lot of changing recommendations. So one thing they're talking about is, do we still do shared clinical decision making? We know it's hard. Do we change it all? And then do we change it to just a standard recommendation based on age and then risk-based for everything else? And then we have both vaccine companies that are already applying for changes of age recommendation. So we have everybody looking down to 50 and then even looking risk-based down to 18 to try to help everybody who wants to prevent RSV disease. So that'll be all a big discussion. And then everybody doesn't know. RSV, was it really just one shot and you're done? We don't think so. But we don't know when that next vaccine booster dose would be recommended. So again, we know that first year is great. The second year, we have some waning. A booster shot in the second year has been looked at. It doesn't seem to change your vaccine efficacy to booster in the second year. So then boosters would be coming later after that. So all waiting to get more information and the June meeting on the ACIP. Okay, switching over to meningococcal vaccines. So when we look at meningococcal vaccines overall, and just the disease trends, we had a good dip like we had for all diseases during COVID. And then during the pandemic and coming out of the pandemic, we have totally gone up, met the pre-pandemic rates. And this last year, this 2023 year, spiked higher than pre-pandemic rates. And so we know our risk factors for meningococcal disease are the late teenage years going into college, and then we have the risk factors of the under 1-year-olds, and then we have the risk factors of people with immune compromising conditions, especially spleen, complement deficiencies, things like that. Then the cases that have happened in 2023, it's mysterious to everybody because the spike is high, and then it's a disproportionate cases in patients aged 30 to 60, that it's not the normal incidence. And then African Americans are disproportionately too high in the last year, and persons with HIV. So a lot of work to be done on kind of targeting vaccines towards that population. So with meningococcal disease, we have to know who's the most at risk. And you guys can see most at risk are the under 1-year-olds, and there are no vaccine products for under 1-year-olds, and I talk about it all the time because shouldn't we focus on them? Because I'm a pediatrician, right? So we should definitely focus on them, but nobody's focusing on them. All the meningococcal vaccines are focused for later in life. So, and it's for the blip that we see at the late teen years going into the early 20s. That's that blip that going into those college years, how to help that blip. And you can see the serogroup typing. So the CWY is light, and then the purple is the serogroup B. So that's kind of a discussion of B is doing most of the disease in the United States the last decade or so. All right, so the ACWY vaccines, this is your normal schedule. You're supposed to do one at the 11-year-old visit, and then you're supposed to boost at the 16-year-old visit. That's been standard for a long time. Then we have the Men B options, and the Men B options, we have the two main vaccine brands, and then it's nice to know what vaccine brand because you can't interchange them, and they have a different schedule. So these are ones where we're preferring to give them between 16 and 18. Bexsero is the 2 doses 1 month apart, and then Trememba we split 6 months apart. So that's our basic, and now we have to talk about a new meningococcal vaccine. So the new meningococcal vaccine literally took the 2 separate ones and put them together. Pfizer's is already out. Pfizer already has been through the FDA and the ACIP. It's out, it's available. And then we have GSK's combined vaccine coming. The confusing thing is, when are we supposed to use it? And basically right now, your ACIP recommendation is when you have a visit where you would be giving ACWY and you would be giving B, just give the combined one. The hard thing is that you're stocking a vaccine and paying for the vaccine up front and then hoping that that magical visit happens where you're combining them anyway. Okay, does this serve the patient best? Does it help, those school requirements? Does it reflect the epi? So right now, the recommendations are that we should receive a single dose of, at that late teen visit. We should get that combined vaccine, the ACWY, and then the B vaccine is shared clinical decision-making, right? That difficult process of figuring out risks and what's going on and patient preferences and your preferences. So that's our B decision. Does that really reflect the epi? No, not really. So what is the epi? So college risk, right? It's nice to talk to people about, okay, you're headed off to college, you maybe should get this vaccine. They're like, I don't want another vaccine. So then go through risk factors. And it's nice to say that, okay, you're going to a 4-year college instead of a 2-year college. This is a higher risk. And then it's nice to say you're going to be living in the dorms. And the dorms and being on campus is a high risk factor. And then it's nice to say your first year there will be a high risk factor. And then it's nice to say you're planning on being in a fraternity. That's an incredibly high risk factor. So it's nice to be able to talk those through with patients as far as their risk factors. All of those are for B because all college outbreaks have been type B. So in the last, I think we're on the 9th or so year of it. Pretty much all of our bigger outbreaks have been B. Okay, how long does immunity last? So the ACWY, we think that immunity lasts, we last definitely 5 years. We might be as long as 8 or 9 years for that vaccine. And then the MenB protection is much shorter. We don't know how exactly long it is. Some data says we're up to a 3rd or a 4th year, but most of the data shows we're really good immunity the 1st and 2nd year. So why are we vaccinated a 16-year-old if we really wanted them protected when they're 19-year-old, right? So that gets us to February ACIP meeting when the big discussion is, do we need to change everything with what the schedule is with meningococcal vaccines? And that was literally the discussion. And the discussion was, do we keep everything current, which doesn't really reflect epi and doesn't really reflect the difficulty we see with shared clinical decision-making recommendations, or do we change everything? And so ACIP talked about, let's look at all the options and change everything. And no decision was made. Everything was on the table, more studies. It's going to be concluded, we think, at February 2025 ACIP. Again, I'm leaving it mysterious as what's going to happen, but I just think you guys should know that it's a big discussion point. In my practice, I am pushing MenB out to the 17, 18 if they promise to come back. If they're not good, if they're not going to show up between 16 and 18, you catch them whenever they can. If they're families who are regularly showing up every year like clockwork, then you have a discussion point with them. Yeah, all options are on the table. Dropping the 11-year-old dose is on the table. Pushing all things to a later teen. Your ACWY and your MenB all to the later teen years is on the table. So that's to be continued. Okay, I wanted to update on rabies vaccine. The rabies vaccine is a nice old vaccine with brand new recommendations the last 2 years. And so everyone kind of knows how rabies work. I'm going to skip this one because we're running short, but the virus is 100% fatal. I think that's nice to cover with people. Why do we want to prevent rabies disease? Because it's 100% fatal. The epidemiology is about 60,000 deaths a year. Most of these are from Asia and Africa. One of the big cases that happened with an American dying is because they just come back post-travel from in India. And so as they came back from India, they became symptomatic. I think it was the 5th week after returning, and then recognizing once that person was hospitalized that this was rabies was a shock to everybody. And then she passed away with all the medical support she was given here in the United States. Here's your high-risk areas of the world. You can see it's a lot that's really highly endemic with canine rabies. Sometimes it's easier just to decide where is rabies not, right? Where do we not have to worry about rabies? So instead of having a long list of countries of where it is that we have higher incidence, just focus on, okay, if you're going there, I'm not worried about rabies. So then things are changing because they want you to figure out your high-risk travelers. So your high-risk travelers are people who are going to do things on their travel that put them at higher risk. So camping, hiking, biking, being in a rural area is all high risk. And then there's this big recommendation that if a child is going on travel with you, the child itself is high risk for a dog bite because of, the toddler in there. So how are we changing everything? The ACIP said as of 2022, we should change everything because we should change the risk categories and who's vaccinated before travel. And it's nice just to remember, what was it before? So if you would have traveled to wherever you're going to travel and you are, surrounded by feral dogs and you're trying to just have a nice bike ride, then you get a dog bite. So then you have to get 4 vaccines in a foreign country. You've got to show up in a foreign country and get 4 vaccines done over the next month. You need a 5th vaccine if you have any immunocompromising conditions. And you've got to find rabies immune globulin. The difficulty there is sometimes you can't find rabies immune globulin, which means you've got to fly to a different country or you've got to fly home, and you're supposed to give rabies immune globulin on the very first day of the dog bite, but you've got 7 days, but that puts everybody in this big stressful moment when there is no rabies immune globulin, not in 3 countries, so that happens. So then now the option is to take pre-exposure prophylaxis, which used to be 3 doses over a month, and now it's been moved to 2 doses in a week. 1 dose on day 0, 1 dose on day 7. So that's the new recommendation from the ACIP. And you can see that they've taken the old risk categories and said the old risk categories of you work in a rabies lab, you work around bats all the time, you're in caves all the time, you need your vaccine pre-exposure prophylaxis, and they've changed it now, and we have our travelers who are going to be someplace with a lot of rabies for more than 3 years are for sure getting it, and then we have our travelers of under 3 years who are going to be hiking, biking, they're going to have little kids with them. Anything like that is now plan on pre-exposure prophylaxis on day 0 and day 7. Then this is basically what happens. You get those 2 shots before you go, and if that dog bite happens and you're in a foreign country and you have difficulty, then you need, depending on the category of bite, depending on the category of bite, then you're going to do 1 vaccine dose. If it's a category 2 bite, or if it's a category 3 bite, then you're going to give 2 vaccine doses post-bite. And then no rabies immune globulin. So that's what the big change is try to talk to the travelers, try to talk about risk factors, and recommend rabies vaccine if they're going to go to a place that's high risk. Tick-borne encephalitis, everybody was like, what on earth is this and why on earth are we talking about it? Tick-borne encephalitis, let's go to the vaccine has been recommended by the FDA for the last few years for any travelers going to Europe to hike in any of the countries there. This is a vaccine that's been given for 20 plus years in Europe. It's universally recommended in some countries for all citizens of that country. And then basically if you're going to travel then in any of these countries, then it is recommended at this point. Sorry. I think people just need to know that the reason is this is not the case fatality rate that rabies is, but it's also not good. So everyone's going to get hospitalized with this, and everyone's going to have some sequelae from it. Then, I'll let you guys have this one to look over. Basically, it's recommended if you're going there and you're going to be around forest ticks, and then you are going to consider it if you're thinking that maybe you might wander into a rural area in Europe and maybe hike and be in the forest. These are all updated in the yellow book. So people didn't believe me that literally you're supposed to look at that country and it's going to say pre-vaccinate for rabies and pre-vaccinate for tick-borne encephalitis. So it's real. This is the plan. I'm going to do really fast on chikungunya. This is the areas where in the last 5 years we've had chikungunya outbreaks, and we've had chikungunya high levels of transmission. Chikungunya we get from a mosquito bite, and the word basically means to be contorted, and it's going to make a lot of sense when we talk about what it is, because basically you're going to get sick. You're going to have 1 week of feeling terribly ill and sick, and that's horrible and that's sad. But 43% of patients will have completely debilitating joint pain that's going to last years. So patients travel, they have no idea what chikungunya is. They don't have any idea what's going on. They were sick. They were sick for about a week. They felt really achy and feverish and threw up a few times. And then they're showing up for an ID consult, and they have been in a wheelchair for the past 6 months. And they're so much arthritis and so much like just completely debilitating pain. So this is a patient with the feet just totally inflamed, and this was a year out and couldn't wear shoes the entire year. There's no treatment for this at all besides supportive treatment, and preventing mosquito bites is your main plan until now, and the FDA is now recommending that we vaccinate our travelers for chikungunya. And basically you're looking at the map, right? So it's those places where you're going where there's high risk of an outbreak, where an outbreak is currently happening, or there is transmission documented within the past 5 years. And then talk to patients about the risk factors and just say, yeah, you're going to work really hard on mosquito prevention, but think hard about the vaccine, because it's one shot. It's got really great seropositivity rate after one shot, and that protection against the severe chronic effects of the chikungunya virus. So that's all I have. Any questions?
Dr. Smith is our smartest pediatrician at Tanner, and she could probably do some questions offline over here if you want to. Next we'll have